Indication of phototherapy and exchange transfusion in neonate. We know that the neonate with hyperbilirubinemia can be managed in the lower side if it is bilirubin is around how much. In the term infants, it is 16 something in the day in the day one, and two in the day one it is usually rhesus incompatibility and ABU incompatibility. In those cases, you should start phototherapy earlier if you are very much certain that ongoing hemolysis is going to the raising the bilirubin. So day 1 it is 12, day 2 it is 16, day 3 maybe it is 18, and for day 4 it may be 19 or something, and day 5 it is 20. Actually, carnicterus it develops when bilirubin is 20 to 35, 23 on average. It depends when there is concomitant risk factors like hypoalbuminemia, sepsis, the acidosis, prematurity, low birth weight, asphyxia, and neonate with total parental nutrition, they have higher possibility of bilirubin encephalopathy by crossing the bilirubin blood barrier. So thereby these children have lower side of the bilirubin level will be 2 milligram per deciliter lower than the said values. In the day one it may be 12, day two may be day one it may be 6, day two it may be 12, and day 3 14, 13, 4, 5 something, and day 5 it is 15, because the connectors can develop with the risk factors in the lower bilirubin. So the diagnosis, the first one day it is usually the blood group incompatibility, rhesus, ABO, and at times minor. In the other in the spectrum, 2 years and the 2 months, 2 days and beyond, it is usually the sepsis, the hematoma, the hemolysis breakdown, and other processes of exaggerated physiological jaundice up to day 7 or something. The second week and onwards, you have the direct bilirubinemia, conjugated hyperbilirubinemia, which is not that neurotoxic and which doesn't respond to the phototherapy. So apart from the phototherapy, what we do, we can give little bit of phenobarbital. It increases the bilirubin conjugated the unconjugated hyperbilirubinemia, and helps in the elimination. The albumin infusion, and it binds, it reduces the unconjugated bilirubin, and the IVIG is said to be helpful because it decreases hemolysis. So there's no specific definite therapy where you should start the bilirubin. So for preventing encephalopathy and phototherapy or exchange transfusion, but they usually these are the roughly these are the figures like, and when at times you are despite every effort the patient has gone too far, you have a higher amount of bilirubin, 25 something milligram per dl, and when you have ongoing hemolysis, when you have connectors early features, when you have severe anemia, maybe hydrops fetalis presentation, then you go for the double dose, double volume exchange transfusion. So, these are the ways that you handle the neonatal hyperbilirubinemia, unconjugated one, and you see. So there are, you see the risk factors over there. There are obviously a fluid take good amount of time. Ongoing hemolysis, when you expect the bilirubin is going to have the raised value, you start phototherapy in earlier 2 milligrams something earlier. When you have very much certain it's going to be stable, then you can you can wait, start it a little bit later. So and in between you have you have other ways, expose sunlight exposure and others.